Good morning, good afternoon, good evening, everybody. It is 6 p.m. in Paris, 12 p.m. in Boston. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in France, and it is my great pleasure and honor to welcome you all to this post-ASH webinar brought to you by the International Academy for Clinical Hematology. Today, we're very thrilled to bring you an in-depth look at the key highlights from the last ASH Congress held in San Diego, specifically in the field of acute myeloid leukemia or AML, a disease that continue to challenge and inspire the hematology community worldwide. As you all would agree with me, the ASH Congress remains one of the most anticipated events in our field, showcasing cutting-edge research, breakthrough therapies, and new insights that usually redefine the way we understand and treat hematologic malignancies. And this year's Congress has been no exception, with pivotal studies, innovative therapeutic strategies, and paradigm shifting concepts presented in the rapidly evolving landscape of AML. So in this webinar, we will take you through some of the most impactful updates from ASH 2024 regarding novel therapies, maybe insight into precision medicine, the role of NGS, also some other immunotherapeutic breakthrough, and of course, the impact of real-world data. And we are very privileged to have a very distinguished speaker and expert, namely Dr. Maximilian Stahl from the Dana-Farber Cancer Institute in Boston and Harvard Medical School. So Maximilian, thank you very much for joining us today and for dedicating time to summarize the latest evidence presented at ASH 2024. So on behalf of the whole IICH team, I want to thank you all for joining us today. And whether you are a clinician, a scientist, researcher, trainee, students, nurse, another healthcare professional, I hope this webinar will serve as an invaluable resource for your practice. So without further ado, let's get started. Maximilian, the floor is yours.
Thank you very much, Dr. Moti. Thank you very much for the invitation. It's really a pleasure to be here. And as a side mark, I think Dr. Moti really organizes the best meetings in our field. So it's always a pleasure to join those meetings. So I was tasked to summarize a couple of highlights in the field of AML from ASH. And what I thought I'll do is give you a couple of abstracts that I thought were clinically really relevant in the field. And of course, we cannot talk about every single abstract at ASH, but I tried to group those abstracts a little bit into topics that inform our clinical management. So the first one is I'll talk about intensive chemotherapy approaches and how to select them for so-called secondary acute myeloid leukemia in the frontline treatment setting. I will then talk a little bit about intensive chemotherapy plus FLT3 inhibitors in FLT3 mutated AML. Then I switch gears and talk about treatment of AML with novel triplet-based approaches that are based on HMA venetoclax in combination with targeted therapy. And then lastly, I'll talk about, I think, one of the hottest topics in AML, so-called Menin inhibitors. So we'll get started with the first one in a second. For each block at the end, I'll give you some of my own takeaways from this topic. And I'll also pose some open questions and try to outline some future directions that will point towards where the field might be going in the next couple of years. So let me start with intensive chemotherapy for secondary AML. So if we think about AML, Dr. Moti already mentioned this, we more and more define this now genetically. And colleagues at Dana-Farber, namely Coleman Lindsley, has defined AML by its ontogeny. And we know there are so-called initiating driver mutations, so-called CH mutation in the form of TET2, DNMT3, and ASXL1, but those are not sufficient to cause leukemia. We can acquire so-called de novo driver mutations in the form of NPM1, CP-alpha, core binding factor leukemia. We call this de novo AML. There's a variety of other mutations, mainly in splicing factors, as well as epigenetic regulators, that characterize so-called secondary AML, so AML that go through a phase of often myelodysplastic syndrome. And lastly, TP53 mutated disease, as TP53 mutated AML is its own disease category. And I think one of the big questions is really, how do we treat secondary AML? So I'll outline this here. We do know that when patients get treated with intensive chemotherapy, generally they have poorer outcomes when they have secondary AML compared to de novo AML. But what has not really been well understood is how to select the appropriate chemotherapy for secondary AML. And this is where the first abstract, actually from our group here, Dana-Farber, came in. This was looking at the pivotal trial that got liposomal 7 and 3, CPX351, approved for AML. But the current approval criteria, at least in the US, is AML with myelodysplasia-related changes or MDS-related cytogenetic categories or post-cytotoxic chemotherapy exposure. So it was based entirely clinical and cytogenetic criteria to select the treatment. The open question now is, that what is the role of really mutations in the current diagnostic AML landscape? We know that although the label says AML-MRC and therapy-related AML, already our definition of AML has changed. We do know that, I'll go back one slide here, we do know that therapy-related AML is biologically heterogeneous. We also know that AML-MRC really does not even exist anymore in the WHO or in the ICC criteria. So can we put this into context by defining AML by the mutation that it carries and what ontogeny of AML is? And this is what the group did. My colleague, Dr. Shai Shimoni, looked at CPX351 versus 7 and 3, first in TP53 mutated patients and in patients with so-called de novo ontogeny mutations. And what he found was that really in those subgroups, CPX351 had no benefit over 7 and 3. However, when he looked specifically at patients with so-called secondary ontogeny mutations, so those are mutations in splicing factor genes or epigenetic regulators, this is where really the benefit of CPX351 manifested itself. And looking further at the role of transplant, although the rate of transplant between CPX351 and 7 and 3 treated patients was not significantly different, when he looked at the transplanted patients with secondary ontogeny, those were really the patients who did benefit from CPX351. Patients who were not transplanted, there was no benefit of CPX351 over 7 and 3. He also looked at count recovery. We know CPX351 can lead to delayed count recovery, and this was the same among all ontogenies. So what he really concluded from this is that so-called secondary mutations drive the benefit of CPX351 over 7 and 3, and this benefit is associated with better outcomes post-transplant consolidation. There was no benefit in CPX351 over 7 and 3 in TP53 mutated patients, however. So the question now is, the trial that this was based on was really focused on patients who are 60 to 75 years old. That was inclusion criteria for the trial. But there is an open question now, what to do for patients with so-called secondary ontogeny who are younger than 60 years old, because those were not really included in this trial. And this was the second abstract that was informative for this particular group of patients. And this was presented by the UK group, which was a secondary subgroup analysis for the UK NCRI AML19 trial. So just to put that in context again, I mentioned this in the CPX351 versus 7 and 3 trial, which I just presented, was patients 60 to 75. In the AML19 trial, it was patients 18 to 60, and they were randomized between FLAG-IDA and CPX351. Overall in the trial, there was no benefit for one treatment over the other. But again, this was not looked at by the specific molecular ontogeny as defined by mutation. So this is what they did in their analysis. They focused on so-called secondary ontogeny AML. And when they focused on that subgroup, it was pretty clear that both OS and relapse-free survival was significantly better for patients treated with CPX351 compared to patients treated with FLAG-IDA. And this was not based on, or this was not explained by differences in the morphologic remission rate between the arms. As you can see here, the morphologic remission rates, CR and CRI, were not statistically significantly different. If anything, numerically, they were a little bit higher for FLAG-IDA. However, when they looked at the transplants rates, a lot more patients in the CPX351 arm were transplanted compared to FLAG-IDA, and patients who were transplanted had better outcomes if they were treated with CPX351. Lastly, they looked at safety between the regimens, and although the early mortality rates were similar between CPX351 and FLAG-IDA, when they looked later out, they found that CPX351 resulted in considerably less infections, neutropenia, and thrombocytopenia. Again, no difference in outcomes for TP53 mutated patients. So what is the takeaway from this first two abstracts? I think in patients with so-called secondary ontogeny AML, as defined by mutations, CPX351 leads to superior overall survival compared to FLAG-IDA in patients less than 60 years old, and compared to 7 and 3 in patients who are 60 to 75 years old. And this benefit seems to be mainly driven by higher rates of allotransplant and better outcomes post-transplant in patients treated with CPX351. What are some of the open questions and future directions? Number one is, how is the survival difference in transplanted patients really explained? Although there's no difference in morphologic response rates prior to transplant. And this is an open question. It could be there are different MRD rates. MRD was not measured in any of those trials, so cannot be easily answered with those trials. Could be difference in adverse events, I showed you that, or could be difference in other things like the microbiome, which we know is differently affected by different treatments. The second question is, how does CPX351 compare to patients who are treated with HMA-Menin in patients with secondary AML? And this is actually an analysis that we presented, it is now published also, that looked at the efficacy of HMA venetoclax versus intensive chemo in secondary ontogeny AML. This is from our group, and this was a large international analysis that contained 1,100 patients. And what we found is that when we compared intensive chemotherapy versus HMA-Ven in patients who are older than 60, no difference in survival. Same for patients who are 60 to 75, no difference in survival. And in patients who were transplanted, there was no difference in survival either. And when we did a multivariable analysis, what we found is that really HMA-Ven was actually superior to 7 and 3 in this age group. And the most important thing was transplant. So I think this is an open question whether in patients with secondary ontogeny, we should actually move away from chemotherapy and towards HMA venetoclax-based treatments and bring as many patients as possible to transplant. Okay, so I'll switch gears and talk a little bit about intensive chemotherapy plus FLT3 inhibitor for FLT3 mutated AML. First, I'll talk about the 10-year follow-up from the RATIFY trial, which really got the first FLT3 inhibitor approved. This was presented by my colleague, Dr. Stone. And what you can see, even after 10 years, patients treated with midostaurin had still an overall survival benefit. Importantly, those patients who were transplanted did better than those patients who were not transplanted. And lastly, patients benefited if they had NPM1 co-mutations or chromatin spliceosome co-mutations. Patients with TP53 did not benefit from addition of midostaurin. So the big question now is we have different FLT3 inhibitors approved. We have quizartinib now approved in the frontline setting. And we also have gilteritinib approved for relapse refractory AML. Both quizartinib and midostaurin have been compared to placebo in the randomized phase 3 trials that got them approved. However, there was not a comparison in a randomized setting of a second-generation FLT3 inhibitor compared to midostaurin. This is where the PRECOG study, which is the next abstract that I'm going to present in, came in, which compared 7 and 3 plus midostaurin compared to 7 and 3 plus gilteritinib. This was a randomized phase 2 trial for patients 18 to 70 years old. And the primary outcome here was FLT3 mutated MRD negative CRC, or composite response rate after induction. Here's a trial schema for the PRECOG trial. Again, as I mentioned, those were FLT3 mutated patients, both TKD and ITD. They got treated either with 7 and 3 gilteritinib or 7 and 3 plus midostaurin, and then received HiDAC gilteritinib or HiDAC midostaurin for consolidation treatment. And what you can see here is the distribution of patients. About half of the patients had a concurrent NPM1 mutation. When you looked at the composite CR rate, this was a little bit higher for patients treated in the gilteritinib group compared to midostaurin. However, when you looked at the FLT3 MRD negative CR rate post-induction, that was actually not statistically significantly different between the two arms. So this was the primary endpoint of the trial, so there was no difference in the primary endpoint. However, when they looked later on in the patients who later on converted after induction with additional chemotherapy and target therapy to an MRD negative state, that was indeed higher in the gilteritinib arm. 83% converted to MRD negativity compared to only 44% in the midostaurin arm. So where does that leave us in the space of FLT3 inhibitors combined with intensive chemotherapy for frontline treatment? I mentioned 2 FLT3 inhibitors, midostaurin and quizartinib, are approved for the frontline treatment of FLT3 mutated AML. We know that long-term OS data, as I just have shown you from the ratified trial, show continued benefit. Also, the benefit was diminished over time. This was likely due to aging and post-protocol therapy. And we know that the assessment time point for MRD matters. That's what I showed you just in the PRECOG trial, that it mattered whether you assessed MRD post-induction versus post-consolidation. What are the open questions and future directions? Well, the most pressing open question is, what should be actually the frontline choice for FLT3 inhibitor for FLT3 mutated AML? Should it be midostaurin? It's approved. Should it be quizartinib? It's approved as well. Or should it be gilteritinib based on the PRECOG trial? I think that's too early to tell because we do not have survival data yet from the PRECOG trial. The big question is, will higher FLT3 ITD MRD negative rate with gilteritinib compared to midostaurin, as shown in the PRECOG trial, at least later on during consolidation, translate into better relapse-free survival and overall survival? Only longer follow-up of the PRECOG trial will show this. What is the best maintenance approach? Should we give quizartinib pre-allotransplant? It's approved for this indication. Or should we give gilteritinib post-allotransplant? Or should we only give maintenance therapy for MRD positive patients? I think all of those are still open questions. And most importantly, what about triplet treatments? I will show you in a second some data about hypomethylating agent plus venetoclax plus FLT3 inhibitor. And this could be even combined with a fourth drug, Menin inhibitor in NPM1 co-mutated disease. How will that compare to intensive chemotherapy plus FLT3 inhibitor? So I think those are all open questions that future trials will have to explore to best define the treatment approach for those patients. So that gets me seamlessly to the next topic, to the first-line treatment of AML patients, not with intensive chemotherapy, but with HMA-Ven-based triplet approaches, where we combine HMA venetoclax, which is approved, with either a FLT3 inhibitor or an IDH inhibitor. There were 2 abstracts. The first one was presented by the group at MD Anderson, which looked at the long-term survival of FLT3 mutated AML patients treated with HMA venetoclax plus a FLT3 inhibitor. And they used several different FLT3 inhibitors. This is a schema of patients that were treated with gilteritinib, but they also had patients who were treated with quizartinib. And what you can see is here, it's a distribution. Most patients were either treated with gilteritinib or quizartinib, some patients with sorafenib. The majority of patients were ITD. Overall, high response rates. So overall response rate, 99%, CR/CRi rate, 93%. Importantly, this was after they amended their protocol several times to change the administration of the agents to prevent cytopenia. So cytopenia, treatment-related cytopenia is a big issue with triplet approaches, and they introduced early bone marrow biopsies and stopped agents when patients were in remission early on. Here is outcomes for their FLT3 ITD and TKD patients. I want to focus your eye on the right side and the median overall survival here, and compare this with outcomes for patients from the VIALE-A trial who had a FLT3 ITD mutation. We know they don't do well with HMA venetoclax alone. So if you compare the outcomes here, ITD patients had a median overall survival of 28 months. In the VIALE-A trial, only 9 months, 9.9 months. TKD patients here had a median overall survival of 39 months. In the VIALE-A trial, again, only 19 months. This is not a randomized comparison, but it looks very promising. What were patterns of resistance? So importantly, for patients who progressed, 65% were actually FLT3 negative at relapse, and they acquired different mechanisms of resistance. And I'm just summarizing the important ones here. The most frequent one was the acquisition of RAS pathway mutations in 24%. There was also patients who got a GATA2 mutation, spliceosome mutation, and the FLT3 TKD mutation. So the most important resistance mechanism, we have seen this before, is again RAS pathway mutations. Okay, the second abstract, also by the MD Anderson group, looked at azacitidine plus venetoclax plus ivosidenib in IDH1 mutated MDS AML. This comes based on data from both the VIALE-A trial and the AGILE trial. VIALE-A that looked at AZA-VEN showed really that the median overall survival in IDH1 mutated patients was suboptimal, only 10.2 months. In the AGILE trial, where you combined the IDH inhibitor with azacitidine, promising 29.3 months. So what can you do? Can you do better if you give all three agents together as a triplet approach? And that's what they did. This was both a phase 1b that went into a phase 2 trial where they escalated the doses and expanded then the triplet regimen. And what you can see here, both in MDS-MPN, newly diagnosed AML, relapsed refractory AML, the response rates were very high, around 90 to 100%, and included high rates of MRD negative response. So very promising response rates. When they looked at the overall survival, again, median overall survival at 3 years was not reached, was 71%. That compares quite favorably to what I just showed you in the VIALE-A trial. And patients who received a transplant had improved outcomes, which is not surprising, but patients who were transplanted really had excellent outcomes, as shown here in the blue curve. So what is the summary of triplet approaches in AML? I showed you that triplet approaches have very high response rates and improved overall survival compared to historic control HMA-VEN doublet approaches. Again, none of those trials were randomized, so those trials will have to be done. But at least to historic control, it seems much better. And I show you the numbers here. For FLT3 ITD, they showed a median overall survival of 28 months compared to 9.9 months in VIALE-A. For TKD, median overall survival of 39 months compared to VIALE-A, 19 months. And for IDH1 mutated leukemia, the median overall survival was not reached at 3 years versus 10.2 months median overall in VIALE-A. However, there is increased myelosuppression, which needs to be mitigated. What are questions and future directions? So I think the most pressing question is, should triplets become the new standard of care approach for FLT3 and IDH mutated leukemia patients who are eligible for intensive chemotherapy? The final answer can only be delivered by randomized clinical trials, which are ongoing both in the United States and in Europe. What is a better frontline approach for patients eligible for intensive chemotherapy? So should they be treated by an HMA-VEN-based triplet targeted approach or intensive chemotherapy plus targeted agent? Again, this is where we need randomized clinical trial data. And then lastly, do co-mutations such as NPM1 RAS mutations impact treatment selection? And how do we incorporate MRD in our longitudinal treatment selections? So all of those, I think, are open questions, and a lot of future investigations needed to figure this out. And this gets me to the last topic here, last big block, which is probably one of the most promising new agents in AML, which are Menin inhibitors. And there was data presented both for the relapse refractory setting, first-line setting, and as well as MRD positive AML setting. And I'll focus just on a couple of the many abstracts that I thought were worthwhile mentioning. So just as a summary, Menin inhibitors are now being explored in NPM1 mutated AML and KMT2A rearranged AML. They share one common pathophysiology or mechanism of disease, where we know Menin is the critical cofactor for KMT2A, and KMT2 rearranged leukemia, NPM1 mutated leukemia, leads to increased HOXA9 MEIS1 expression, which then leads to a differentiation block and leukemia development. And this can be released, this differentiation block, by blocking this cofactor Menin in this big complex that blocks differentiation. And if the cofactor is blocked, then this block is released and cancer cells can differentiate. And this is a busy field now. I'm just showing you 4 different Menin inhibitors, all this data presented at ASH. We have revumenib, we have enzomenib, we have pleximenib, and ziftomenib. And revumenib is the only one that is approved now in the US for patients with relapse refractory KMT2A rearranged leukemia, but it's quickly followed by all those other Menin inhibitors. And I'll talk a little bit about all those different Menin inhibitors. The first abstract actually focuses on a new Menin inhibitor, enzomenib, which just like revumenib is now studied in relapse refractory leukemia first. And what you can see here is the structure of the different Menin inhibitors is all slightly different. And that leads to different drug characteristics. And enzomenib was specifically designed to have low lipophilicity and basicity, which leads to a low volume of distribution and very minimal accumulation. That's shown here. And this trial was tested just similar to revumenib in patients with relapse refractory leukemia, both with and without azoles, to establish a recommended phase 2 dose. The important things to emphasize here is that there was about 48% were KMT2 rearranged relapse refractory leukemia, 27% were NPM1 mutated leukemia. And those were heavily pretreated patients, including about 80% had prior venetoclax treatment. Importantly, there was no DLT seen at any of the dose levels. The QTc prolongation was rarely seen here. This was an important side effect with revumenib, but was rarely seen with enzomenib. There was some differentiation syndrome, just as we have seen prior with revumenib. And the response rates were quite promising, similar to revumenib. A good response rate both in KMT2A rearranged and NPM1 mutated leukemia. So with all those Menin inhibitors now, can we do combination therapy? Of course we can. This is a triplet approach that has been pioneered by MD Anderson. The SAFE trial, which looked at the combination of an all-oral regimen, revumenib, oral decitabine, and venetoclax in relapsed refractory AML. And what you can see here is this is a study design where they combined all 3 agents. Importantly, going back here, was a mix of KMT2A rearranged leukemias, NPM1 mutated leukemias. They also had a couple NUP98 rearranged leukemias, and just like prior, heavily pretreated patient population. Importantly, lower rate of differentiation syndrome overall than compared to single agent. QTc prolongation was present as expected. Overall response rate quite good. 82% of patients had an overall response rate, and 48% of those heavily pretreated patients had a CR/CRh. And within CR/CRh responders, 88% were MRD negative by flow. And with a median follow-up of 9.3 months, they had 6 months overall survival of 68%. So this was in the relapse refractory setting. What about Menin inhibitors combined with intensive chemotherapy, the frontline treatment of AML? This was presented by my mentor at Yale, Amr Saiden, who presented the trial of ziftomenib in combination with 7+3 standard induction chemotherapy in NPM1 mutated or KMT2A rearranged acute leukemia. This is the trial schema. Different dose levels of ziftomenib, combination with 7+3, were explored and then expanded once the recommended phase 2 dose had been established. And this enrolled, again, both patients with NPM1 mutated and KMT2A rearranged leukemia. Here are the patient characteristics. As you can see, a typical population for induction patients. In terms of side effects, I think those are the expected side effects that you would see with intensive induction chemotherapy. And it was not any new side effects that I would say were unexpected. In particular, no significant differentiation syndrome here, and no particular increased QTc prolongation. This is important because those were the side effects, I think, that limited the use in the relapse refractory setting as single agent therapy. Here are the response rates for both patient populations, very high response rates. So for NPM1 mutated leukemia patients, 100% had a composite CR, 83% for KMT2A rearranged leukemia, and high rates of MRD negativity as well, 76 and 75%. One interesting presentation that was shown here that I think is of critical relevance for investigators and clinicians who treat patients with Menin inhibitors is this example of a patient who had a mid-cycle marrow and actually had blasts on the mid-cycle marrow. But on closer examination, the blasts were actually initially diagnosed, the blasts were CD34 negative, NPM1 positive, and then in the mid-cycle marrow, there were CD34 positive, NPM1 negative by IHC. And no reinduction was chosen, and it was just observed. And what they found is that those blasts actually went down on a subsequent marrow. So those were actually recovering, differentiating blasts, and not truly leukemia blasts anymore. So I think that's important to look at, that you can get this differentiation effect in the marrow when you do mid-cycle marrows, when you combine Menin inhibitors with intensive chemotherapy. And then the last abstract that I want to emphasize is an abstract from Scott Armstrong's lab here at Dana-Farber that looked at the landscape of Menin inhibitor resistance. And I think that's very important because we have now so many different Menin inhibitors. Is the resistance pattern different between those Menin inhibitors? So we do know from the Augment 101 trial, which looked at revumenib in the relapse refractory setting, a single agent, that that it was efficacious, as shown in the trial. 30% had a response. However, 39% of patients required a mutation in the target of the Menin inhibitor, in MEN1. And this grew out fairly quickly for patients on trial. So we do know now that we have different Menin inhibitors, and they bind on different sides to Menin. So the hypothesis of the group was that MEN1 mutations will arise with each Menin inhibitor, but they will arise in different spots, in different areas of MEN1, and that they can use CRISPR screens to predict preclinically where those mutations might be. And that's important because we don't have any mutational data or resistance mutational data published for all the other Menin inhibitors yet. So we don't really know clinically what are the resistance mechanisms to Menin inhibitors outside of revumenib. So this is kind of ahead of its time in a way to look at like what we might predict based on the binding behavior. So what they did was a CRISPR screen with all the newer Menin inhibitors and looked at what mutations grew out and made this, the leukemia cells resistant to the Menin inhibitor. And what they found is that the top enriching guide RNAs in the CRISPR screen matched quite well with the binding sites of the different Menin inhibitors. So you can see that up there, the crystal structure with the red binding sites, and then on the bottom you see the mutations in MEN1 that actually predicted resistance to the different Menin inhibitors. And those overlaid quite nicely with the binding sites. And you can see here the CRISPR-Cas9 screen that they did. And importantly, they could reproduce the MEN1 mutations reported in patients who were receiving revumenib. But most importantly, they found novel MEN1 mutations that have not been prior reported yet. And when you look at one Menin inhibitor here, enzomenib, they could predict that there were mutations, and they wanted to see now if they expose cell lines to a Menin inhibitor over time, would actually in vitro cells rise up that acquire this mutation under the pressure of Menin inhibitor, and they could actually observe this. So over time, they got exactly the type of mutation that they would predict from their CRISPR screen, that it rose up. Importantly, though, when they looked at the sensitivity of this acquired mutation on enzomenib, they saw that the other Menin inhibitors remained sensitive to this mutation. And I think this has big clinical implications, because it could mean that, similar to CML, where we have tyrosine kinase inhibitors that target different mutations, the ABL kinase, that are resistant to another tyrosine kinase inhibitor, that this could also be true for Menin inhibitors, meaning that we have Menin inhibitors that are resistant against certain mutations, but others remain sensitive. This is important for the sequencing of therapy. So here's my summary and takeaway from Menin inhibitors for this year's ASH. Menin inhibitors are active. We know this now in KMT2A rearranged and NPM1 mutated leukemia. We have one Menin inhibitor, revumenib, approved for relapse refractory KMT2A rearranged leukemia. We expect the approval in relapse refractory NPM1 mutated leukemia as well. This is a crowded field, as I have shown. There are multiple Menin inhibitors in first line and in relapse refractory AML, in combination with chemotherapy, in combination with HMA venetoclax, in combination with target therapy, and even for MRD positive disease. I haven't shown the slides of the Intercept trial yet, but Andrew Way from Australia also showed data in MRD positive AML. Future questions and directions. Do we need all those different Menin inhibitors? I think that's a fair question. Do you need all those Menin inhibitors? I would argue maybe yes. I showed you that there are different binding residues, and hence the resistance mutational pattern differs between Menin inhibitors. So future sequencing or combination approaches might be used to overcome those acquired resistances. Of course, we have to see, does the backbone matter when studying combinations? There was some data presented at ASH that FLAG-IDA is superior to daunorubicin cytarabine in the NCRI trials. I think that will be an open question. And can we approve combination therapies based on MRD endpoints rather than overall survival? This is important because NPM1 mutated leukemia patients generally have a favorable overall survival. So showing differences between chemotherapy plus minus Menin inhibitor will require huge sample sizes. So can we instead approve drugs similar to multiple myeloma based on NPM1 MRD? I think that is an open question, not only for the research community, but also for regulatory bodies such as the FDA in the United States. So with that, I stop just to give us plenty of time for discussion. Thank you very much.
Thank you very much, Dr. Stahl, for really a fantastic overview. I think you have nailed it nicely, very nicely, and it is very exciting to see all of these developments in the field of AML. I do remember a few years ago there was a the cover page from the Lancet journal, and they were actually covering the 3+7, saying we're celebrating almost 50 years of 3+7. And are we making any progress? Something like this. I'm sure I can find it using Google. So we have a lot of questions. So thank you all for joining us again. This is the ICH. In your practice today, who are the patients who are still candidate for an intensive induction 3+7 or similar?
Yeah, that's a great question. So, if you would just follow literally what a lot of the practice guidelines, I think, say, there's a lot of emphasis on age. So if you are age 75 and unfit, you can get HMA venetoclax. If you're less than 75 and fit for intensive chemo, you should get intensive chemotherapy. I think we're moving away from that, from this clear dichotomy between you're either magically now you're above 75 and we're going to give you less intensive treatment, and anything less than 75 should get intensive chemotherapy. I think we're moving much more towards a biologically informed approach. And that's why I showed the data in patients with secondary mutations. So we really here at the Dana-Farber have, even in patients who could technically get intensive chemotherapy, but they have a secondary mutation, we give those patients either CPX-351, not 7 and 3 anymore, or we give them HMA venetoclax. We know they need to go to transplant. That's really the most important part of the treatment. And I do think that beating patients less up with intensive chemotherapy and getting them to transplant in a better state, I think, is a better way to do it. We do have actually a randomized phase 2 trial here that compares 7 and 3 versus HMA venetoclax independent of age. So you could be 30 years old and with some exclusions such as core binding factor leukemia, but all other AML could get either HMA venetoclax or intensive chemotherapy. And that trial, I think, will be very critical to see, can we get away with chemotherapy in a lot of patients?
Wonderful. Thank you very much. We have several questions in line with this issue of chemo versus non-chemo approach. And Dr. Saglio and many other colleagues are asking, which subgroup of patient where you feel a sort of a chemo-free regimen can be developed successfully? Sort of a speculation. And it reminds me, last week we were discussing the Philadelphia positive ALL and the amazing result achieved with TK inhibitors and blinatumomab. So what are your thoughts on this?
Yeah, so really, this is really speculating a little bit now, because we do not have the randomized data. But just where I would think the field will go, I would hypothesize that in a couple of years, there's going to be very specific subsets where we still give intensive chemotherapy. I think those are probably the patients who we know that with a good chance we can cure them with chemotherapy alone and without a transplant. And those are patients with core binding factor leukemias, those patients with double CPP alpha mutations, and maybe subsets of NPM1 mutated leukemia. For most of the other patients where I think we really need a transplant for a curative approach, my hypothesis is that really chemotherapy is going to play less and less of a role, and we're going to give much more HMA venetoclax either as a doublet or triplet approaches, such as I have shown, to get them to transplant better. But I think the next couple of years will be very exciting because, until a randomized trial is done, you never know for sure.
Excellent. Thank you very much. So we have another question from Dr. Dragani, but this is also in line with other questions, whether based on the NGS data, do you feel that some groups, young and fit patient today, should be actually excluded from high-dose chemo, like complex karyotype, because we know that the CR rate is going to be relatively poor?
Absolutely. Actually, our practice here in Boston, in our department, is for patients who have truly biallelic TP53 mutated disease. So either 2 mutations of TP53 or loss of heterozygosity or complex karyotype plus TP53. For those patients, we do not give them intensive chemotherapy, independent of what their age is. We know that transplant is critical in those patients, although it still leads to suboptimal outcomes, but it probably leads to better outcomes than chemotherapy alone. And so those patients we usually treat with HMA or HMA venetoclax-based approaches, and then try to get them to transplant as quickly as possible. But we really do not give those patients intensive chemotherapy anymore.
So we have another question from Dr. Dragani asking, well, in many places across the globe, people do not have instant or immediate access to NGS results. So in this situation, how would you tackle this problem? What would be your advice for a sort of a by default induction?
Yeah, that's a good question. We have a richness of resources, in the Western world. I think that makes us sometimes a little ignorant to like what other people have and what they have to deal with. I do think that that NGS becomes more and more critical. It used to be, even at our center, where we really looked only at FLT3 and IDH because, those were the targetable mutation. But at this year's ASH, that's why I thought this was so interesting. Secondary mutations actually really selected patients for different intensive chemotherapy approaches. So the optimal way is to have this mutational data. I think short of having the mutational data, if you're younger, I think the most important thing is probably going to be to know about the FLT3 status, maybe just focus on that because we know we have approved treatments in combination with chemotherapy there, and know about TP53. TP53 at least can be estimated by simpler methods such as IHC, so we know that if you have very strong patterns for staining for TP53, at least if it's a missense mutation of TP53, it predicts a mutation on the NGS quite well. So that I would use in settings where maybe NGS is not readily available, because what you mentioned before, that I would not give intensive induction chemotherapy to somebody who has very, very strong staining on the IHC for TP53. So that might be a way to at least prevent giving patients intensive induction when they really don't benefit from it.
Excellent. Thank you very much. Now we have a question regarding MRD and allo transplant. Should we use MRD negativity or positivity, of course, to guide allo transplant indication irrespective of the NGS status and biology of the disease?
Yeah, that's a great question. And I think that honestly could be probably a talk on its own, but I'll emphasize a couple of important things I think where MRD is important. So we always know that having MRD is not good. It's always better to not have MRD, but there are only certain situations right now where I would say a therapeutic decision is actually made based on MRD data. And it's not just prognostic, but it's predictive of what you will do. So the two scenarios where I would think that's the case, particularly with transplant, is in NPM1 mutated leukemia. The British have presented now their data from the NCRI 17 and 19 trial, and they looked at NPM1 mutation MRD after double induction. And what they found is that those patients who were MRD negative, at least patients who were younger than 60 years old, did not benefit from transplant in CR1 if they were MRD negative. They still had a lower relapse rate with transplant, but the survival was the same. So I think that's where this is helpful. The second part where I think MRD is helpful, not so much in selecting whether patients goes to transplant or not, is in the FLT3 mutated patients. So we do know now from the randomized trial of gilteritinib maintenance post-transplant that those patients with MRD positivity before transplant or directly after transplant, those were the patients who benefited from gilteritinib maintenance post-transplant, whereas those who were MRD negative did not benefit from that. So I think in those two scenarios, I think it really impacts of what you do, which is more than just a prognostic impact.
Wonderful. Thank you. So we have a few questions about menin inhibitors, and as you have nicely alluded to, this is really a breakthrough. I mean, at some point a few years ago, we had the advent of venetoclax, and azacitidine and venetoclax proved to be a backbone now, and now probably menin inhibitors are coming. So what are the ideal partners for menin inhibitors today?
Yeah, great question. So I do think that definitely we need to do combination with menin inhibitors. There are two main reasons for this. I think number one is that the MEN1 mutations that were acquired, as I've shown during the presentation on the Augment 101 trial, they were acquired very quickly. With sensitive sequencing, they were acquired after just 1 or 2 cycles. And after a couple more cycles, they rose up to a point where you actually got morphologic resistance, you know? So if you just do a Menin inhibitor alone, I think you will get a lot of resistance to this drug. The second part is some of the side effects with Menin inhibitors are also more if you give this as a single agent. So differentiation syndrome is a major issue with this drug. And but this has not been seen when it was given with, or at least not been seen to the same extent, when it was given with 7 and 3, as I showed, as frontline treatment, or in combination with HMA venetoclax. So the combination both makes it more effective and actually more safe as well in terms of differentiation syndrome. So in terms of what is the perfect ideal combination partner, I don't think that has been established there. It's really being combined with every single treatment now, you know, and we'll have to see what is the most effective way of doing it. When you combine it with intensive chemotherapy, for example, NPM1 mutated leukemia, the goal is really to cure more of those NPM1 mutated leukemia patients without taking them to transplant. So keeping the British data in mind that you reach very high MRD negativity rates. With other targeted agents such as FLT3 inhibitors, you know, there's a rationale for targeting multiple mutations at the same time, because we know AML is a polyclonal disease with multiple mutations. So to prevent resistance mechanism for each mutation, there's a good rationale, I think, for combining different target therapies with Menin inhibitors.
Excellent. We'll take one last question because time is running, and this is Dr. Doreen asking about whether one can use Menin inhibitors as maintenance after allotransplant.
Yeah, one certainly can. There are trials, you know, that are now ongoing with Menin inhibitors in the post-transplant setting. I think there's a good rationale for it, and the rationale actually comes particular from the Intercept trial, which I mentioned, you know, during the presentation. I didn't have time to show the slides, but Dr. Wei from Australia showed in his Intercept trial that patients with MRD positivity, you know, not necessarily post-transplant, but just MRD positivity after remission, could actually be converted into an MRD negative state by Menin inhibitors, you know, and that would be the goal, to have patients who remain MRD positive post-transplant to convert them into an MRD negative state. The open question, I think, in the field of maintenance will be, should maintenance be given dependent on what your MRD status is pre-transplant? You know, I think that's an open question for FLT3 with gilteritinib that has been answered, but is the same answer true for NPM1 mutated leukemia? I'm not sure. And I think, you know, a good designed trial will hopefully explore maintenance in both MRD positive and MRD negative patients, then see who benefits from it.
Wonderful. Thank you very much, Maximilian. As we conclude this lovely webinar, it is evident that the ASH 2024 Annual Congress has brought remarkable advancement to the field of AML, novel treatment strategies, novel combinations, better understanding of the genomics of the disease and how we can use it for tailoring treatments. And of course, we had some nice updates about the key clinical trials, which are reshaping, I would say, our view of AML. Thank you all for joining us in this webinar and the lovely discussion. I do apologize we're not able to take all the questions, but I'm sure Dr. Stahl would be more than happy to receive your emails and question. I do encourage you to continue exploring all together the exciting developments in AML and beyond. This is the International Academy for Clinical Hematology across the hematology field and around the globe. Thank you very much. Take care.
Thank you very much.